The first HIV drug treatment appeared in 1986. That medication was zidovudine, commonly referred to as AZT. This compound was originally developed as a cancer treatment, but it was decided that it was too toxic for first-line use, and so it was shelved. Once the HIV virus was discovered in 1983, scientists began testing a number of compounds to see whether they were effective against HIV in laboratory conditions. Most were not, though AZT was, and so it was trialed first in animals then in humans. When these trials were complete, the drug was licensed as the first HIV medication. A number of problems were apparent with AZT early on, however. Firstly, it was very toxic and was given in high doses initially, as doctors did not know what the therapeutic range was, that is, how much needed to be given for it to be effective. Due to its toxic nature, there were many side effects and a few people even died. Most people also very quickly developed viral resistance to AZT, meaning that it quickly became ineffective. Though it did give many very advanced AIDS patients a few extra precious months they probably would not have had otherwise. The attitude of drug companies in relation to AZT left much to be desired as well. It went from being a pretty much useless compound to being the most expensive drug in history overnight. A few years after AZT, another drug in the same class as AZT was developed and licensed, didonosine, or D for short. Be quite toxic like AZT, and resistance quickly occurred once again, though this is slower than with AZT. Therefore, it did give some temporary relief to those already resistant to AZT. Due to widespread toxicity and viral resistance, D is no longer used as a main treatment for HIV. After D, next in the pipeline was lamivudine, or 3GC for short. 3GC was better tolerated by patients than both D and AZT, though there were still quite a few unpleasant side effects. Unlike the other treatments from quite early on, it was used in combination with AZT, which seemed to slow the development of viral resistance and increase the overall effectiveness of entire retroviral therapy. Newer classes of medication were engineered throughout the early 1990s, particularly protease inhibitors, which from that time revolutionized HIV treatment. From 1995, HIV physicians began to use a treatment protocol called highly active antiretroviral therapy, or HAART for short. HAART relies on the administration of 3 or more medications from the different classes we described earlier in combination to suppress the virus. As a result of HAART, people stopped dying from AIDS, and people living with HIV can now live a near normal life expectancy. But these medications only control the virus, they are not a cure. They do prevent people from passing the virus into others, though once their viral load becomes undetectable. It was found that by using different kinds of medication in combination, we could prevent resistance from happening. People living with HIV are able to control their illness as well as anyone living with other chronic conditions such as diabetes. In fact, people living with HIV often have better health outcomes than those suffering from other long-term conditions, including diabetes and heart disease. As we have already said, though HAART is not a cure. If people stop taking their medication, then their virus quickly flares up again, and they will almost certainly develop resistance to the medications they have been taken. Though HAART prevents disease progression and restores health to a damaged immune system, there are still many side effects from HIV medication, including nausea, diarrhea, vomiting, and headaches, to more serious complications such as problems with red blood cells. As more advanced medications are developed, side effects are becoming less common. A final point to consider is that for treatment to be effective, we must ensure that it is available. In many countries, especially those outside the West, HIV treatment is still largely unaffordable for those most at risk.